You ready?
Go ahead and do it. Oh, wait. Da, na, 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 da. What's the Lion King theme song? Simba, you will succeed.
Oh, man.
Sorry about that, Lenny. Welcome back, Clinical Problem Solver, to your Friday edition of Virtual Morning Report. And we already have a case volunteer who's our dear friend and someone who's very active on Twitter. Azim, please unmute yourself, introduce yourself, and let's get your Twitter handle in the chat. But before you do that, I have to interject on myself. Robbie, how are you?
I am doing very well. Somebody here wants to say hi, say hi, say hi, say hi. Come on, say hi, Lenny. Hi, Lenny. He's like, nah, medicine's overrated. I'm doing very well because I got a whole morning with this cutie. We run around, we played fetch, which mostly meant him running towards the thing he was supposed to fetch and then just staying there and me getting to fetch him. So I'm doing very, very well. Thank you for asking. How are you?
I am doing great. After this lovely VMR session, I'm going to take this little monster to the dog park. I'm babysitting for my sister. I guess a dog sitting. I shouldn't say babysitting, but dog sitting for my sister, and we're going to go have some fun. And if Nar was here, we would, play with Nar, but maybe soon. All right, that concludes VMR for today. We'll see you next time. So Azim, please unmute yourself, introduce yourself, and we'll get started.
Hey everyone, my name is Azim. I'm a fourth year at LECOM. Recently matched to my #1 at University of Florida here in my hometown of Jacksonville. It's my first time presenting a case, so hopefully you guys can bear with me, but I think it's going to be a good one.
Azim, congratulations on your match. It's very exciting times for so many of you out there. And we look forward to it. Who's scribing today?
I'm scribing.
Wonderful. Gabriella, if you want to take over the whiteboard, and then who's teaching today?
I'm teaching today.
Oh, oh, great, Rafa. Fantastic. And then Robbie, do you mind tackling the first aliquot? All right, Azim, whenever you're ready, my friend.
Okay, so this is a 33-year-old woman who presents to the emergency department complaining of worsening shortness of breath that began 5 days ago that she said, quote, came out of nowhere. And I'll leave it at that.
Ooh, what a place to start. A world that we're very familiar with, shortness of breath, and a patient population we might not expect to be short of breath. And I think that's the tension in this case. We practiced the dyspnea pyramid quite a few times. And of course, we will remain, no matter what happens, anchored in a cardiopulmonary base, meaning that the lungs and the heart account for the vast majority of patients with shortness of breath. But the truth is, we often are constructing that differential diagnosis for people who are over the age of 50. So how does the lay of the land change in a 33-year-old patient? The truth is that all the diseases we associate with age are becoming more and more common with younger folks because risk factors for obesity, diabetes, tobacco use are expanding into younger and younger populations. I, for example, recently just learned that the most common cause of a stroke in a young patient is a regular old stroke. So the same is true. I imagine you can get early onset ILD. I imagine you can get coronary artery disease at 33. I can imagine many things. But it's harder to solve a problem of 33-year-old with shortness of breath for two reasons. One, it's not intuitive to think about those things. We have to work to think about them. Two, they tend to present a little bit atypically. And three, there are diseases that you have to think about in just people who are young. And Travis just mentioned one of them. Anemia from blood loss is probably more common to be severe enough to present a shortness of breath in younger people. So automatically, we have to extend beyond our cardiopulmonary base to think about anemia, to think about metabolic acidosis, to think about rare presentations of neuromuscular weakness. So what happens? We remain anchored in the cardiopulmonary base, knowing that common diseases are more common in adults, but are still common enough in young people, one. Two, we have to extend to the top of the pyramid because it's unusual for a patient to present with shortness of breath, and less common causes are more probable in a younger person, like hemolytic anemia or anemia from blood loss. But here's the hardest part. The hardest part is you have to go back to the cardiopulmonary base and add things that you wouldn't have added in older people. Spontaneous coronary artery dissection, pneumothorax from Ehlers-Danlos, aortic dissection from a bicuspid valve, pulmonary hypertension class 1 because of an autoimmune disease, so on and so forth. So my antenna is up, and I'm really worried about a 33-year-old with shortness of breath. The question will be, will we find a common cause that affects older people? Will we find a less common cause that can affect older people? Or will we find a cause that is only limited to younger people, like catamenial pneumothorax, as Travis just said? All right, I'll pass the mic back to Azim for Reza to discuss the next aliquot, unless, Reza, you have something to add here.
Okay, that was, I think you're on track because just add some more associated findings. She said that she was experiencing chest tightness, not pain, tightness, that had also been going on for the last 5 days. And here are some pertinent, and she denies having fevers, nausea, vomiting, or abdominal pain. So I'm going to move to the past medical history. So she was recently diagnosed about 6 months prior with cervical cancer, and also with Fanconi's anemia. She also has type 2 diabetes that's uncontrolled. She is obese. She has PCOS. And in the chat, someone was asking, she is COVID negative. And then I'll give the meds and then I'll stop there. She's on danazole, acetaminophen, aspirin, ibuprofen. And actually, to go back to the cervical cancer, she had started 1 cycle of cisplatin and radiation therapy, but she wasn't tolerating it well, and she was switched to IV bevacizumab, and she had just started her 2nd cycle 2 weeks before her complaint of the shortness of breath. And I will stop there.
All right, wonderful. Thank you, Azim. You know, the truth is I don't have the greatest illness script for Fanconi's anemia. So if Robbie has one that he can share with the group, that would be fantastic. So I note that deficiency in my knowledge, but then I analyze the other aspects of this case. It would be helpful to know in that HPI, because we're rooted in a cardiopulmonary world, whether this patient has any signs of volume overload. What might these look like? So this is the hypothesis-driven HPI. I would ask about weight gain, lower extremity edema, orthopnea, paroxysmal nocturnal dyspnea, because now I'm starting to shift the frame from just young and shortness of breath with young cervical cancer receiving platinum-based chemotherapy who's now presenting with shortness of breath. That frame broadens the DDX to both non-cancer associated dyspnea and cancer associated dyspnea. But before I talk about the cancer associated dyspnea, maybe I can ask you, Azim, as far as like constitutional symptoms, any weight loss, weight gain, fevers, lower extremity edema, etc.
No constitutional symptoms, but I will add, because I didn't read it correctly the first time. She said she was having difficulty sleeping as well over the last 7 days and had bad dreams, but no fevers, no lower extremity edema, and that'll be revealed in the physical exam when we get to it.
Sounds great. So, you know, at this point, we assume that we're dealing with an acute to subacute process. So this sort of adds weight to the morbidity of what's potentially causing this. But many times we'll be surprised that maybe there's some kind of pathologic process that's been going on for some time and now is really manifesting in this patient, prompting them to come to the emergency department. So when you think about cancer and shortness of breath, just like a general approach, you can, of course, think about actual lesions within the parenchyma leading to dyspnea. So if you had metastatic disease, you can associate a hypercoagulable disorder, so pulmonary embolism, but you can even have pulmonary tumor thrombus, so that the tumor can manifest in the parenchyma, it can manifest in the lymphatics, and it can manifest in the actual blood vessels. So we talked about the sequelae of cancer itself. Then you can entertain the idea of medications or radiation therapy that can further broaden the DDX of shortness of breath in a patient with cancer. Here, a lot of the chemotherapy agents can lead to a dilated cardiomyopathy. This is when time course would be very helpful. This is another lesion in my thinking, is that I don't see this often, but what I would be looking up right now is, when do we expect, the dilated cardiomyopathy or symptoms from the specific treatment agents that the patient is receiving? So on the physical exam, I'll be paying close attention to the jugular venous pulse, to the lower extremities, to see if there's any signs that can suggest volume overload. So to summarize, I think what the past medical history does is it takes us through two frames. One is shortness of breath in a young person, but we got to layer in the history of cancer. And then we have to think about complications of cancer, whether it's directly linked to the cancer or to the medications or radiation associated with the cancer that might manifest as shortness of breath. Maybe I'll leave the rest for Robbie to tackle whatever he wants to add to that.
Absolutely nothing to add, as per usual.
Okay, so to finish off in the southwest corner, her family history, her maternal grandmother had melanoma and her paternal grandmother had pancreatic cancer, and both of her parents have hypertension and diabetes. She's negative for all social history. No, she doesn't smoke, drink, or use any drugs of any kind, and no drug allergies. So then to the physical exam, for her vitals, she came in with 125 heart rate. Her blood pressure was 167 over 108, and her O2 was 89%. Should I leave it there, or finish through the rest of the physical?
Why don't you give us more data?
Okay.
Thanks, Lizzie.
So the remainder of her physical exam was largely unremarkable. She was like alert, mild distress. Her HENT, there was no obvious deformities. Her eyes were perla, EO eyes were intact. Cardiovascularly, there was no murmur, normal peripheral perfusion, no edema, tachycardia was noted. For her lung examination, it was cleared auscultation, non-labored, but some crackles were heard. No JVD as well. Alert and oriented to time, normal cranial exam. Otherwise, the rest of her examination was unremarkable.
Incredible. Thank you so much. This is a very concerning exam. Maybe I can focus on the vital signs and then pass on the analysis. And the vital sign that raises alarm is the heart rate. And the vital sign that provides specificity to the problem is the hypoxemia. So let's talk about the hypoxemia first. You have to recognize a couple of things. One, that the pulse oximeter used to infer hypoxemia is not perfect. So what the pulse oximeter does is it uses fancy technology to infer what the SAT is and what the PaO2 is. We've learned recently, based on an incredible New England Journal study, how much racial bias affects the pulse ox. With patients who have darker skin are much more likely to have inaccurate pulse oximeter measurements. And you should use that to further educate yourself on the effects of systemic racism within the medical system, being that's something that we just learned in 2021, but also the inherent flaws of the pulse oximeter. And the reason I'm bringing this up now is to highlight this recent gap in my knowledge and growth in my knowledge, but also that there are things that are very acute and important to think of as mimickers of hypoxemia when in fact the patient's not hypoxemia. And that is when there's hypoperfusion. So when there's the pulse oximeter is not being perfused, it might be inaccurate, in which case the blood pressure will probably tell you that. But more importantly, when the hemoglobin molecule is messed up, and that importantly is to consider methemoglobinemia. Now, why do I say that? I say that patients with cancer are more likely to get methemoglobinemia because of the medications that they're on. And that number of 89% is evocative of methemoglobin. So if I saw this in real time, I would think, oh, I'm going to do my usual garden variety stuff, but I would scan the med list to be like, is there a culprit for me not to get an ABG with co-oximetry right now? Because a SAT of 89% may not prompt you to get an ABG in most situations. You just put the patient on oxygen, but there's no way you can diagnose methemoglobinemia without getting the arterial blood gas. So if you see that number, you're like, wait, I'm going to go down the usual pathway, which I'll talk about in a second, but pause. And that pause is, could this be methemoglobin? Because if I don't pause now, I'm going to miss a diagnosis for another hour or 2 or 3. But if the pulse ox is verified, and that verification comes from what happens if you put the patient on oxygen. If you put the patient on oxygen, her SAT goes to 98% on 2 liters, it's not methemoglobin. So you can make a lot of progress with just that alone. But it's, I think, important to stop there before you move on. But if you verify the pulse oximetry, now you've localized the lesion. Oxygen is not making it from the alveolus into the vessel. And the key question is it a primary alveolar problem, something filling or collapsing the alveolus, or is it something in the vessel? There's something filling the vessel, or the vessel is being really far away from the alveolus. What could be in the alveolus? Blood, pus, water, cells. What could collapse in alveolus? Atelectasis. What could happen in a vessel? A macroscopic pulmonary embolism or a microscopic tumor embolism. Or you could be shunting. You could be shunting through a PFO, for example. So hypoxemia, real quick, make sure it's real. And how do you make sure it's real? Through the pleth and through response to oxygen. If the patient responds to oxygen, you're probably dealing with real hypoxemia. And the question is it an alveolar problem or a vessel problem? Clues to alveolar problems are when you hear the alveoli with your stethoscope. You cannot hear a vessel with a stethoscope. So there you have it. I'll leave Reza to study that and everything else. I think that.
Robbie John, I think that what I'd like to highlight actually for my section is there's an incredible schema approach to hypoxemia, which I really think it's one of our best. And Kara Lau, a medical student at UCSF, created this. If someone can please find that and include it in the chat, because it literally takes you through what Robbie just did. And I'll leave it at that. I have nothing else to add, but to say that the lack of jugular venous distension does not rule out volume overload, because we're not perfect at assessing the jugular venous pulsation. So in a patient who's coming in with concern for hypoxemia, we know that we're going to get an electrocardiogram, we're going to get a chest x-ray, and in this particular patient, we'll also get the CBC CMP, and then take it from there. Thank you, Drew.
Excellent discussion. Moving to the next section, the EKG showed sinus tachycardia with T-wave abnormality, but nothing else was interpreted. Then a ABG was actually performed. The patient was at 89 O2 stats and hovered around 87, 88, was put on nasal cannula, then high flow. So the ABG, I believe, was performed prior to the high flow, but here are the ABG values. The PCO2 arterial was 32.1. The PO2 arterial was 49. The bicarb was 20.7. And the O2 saturation was 86. And then the CO2 arterial was 22. And I can give you some more labs in the CBC. So this patient's white blood count was 4.4. The red blood count was 3.14. Her hemoglobin was 12.1. MCV was 108.8. Her MCH was 38.8. Her platelet count was 51. Her neutrophil percentage was 72. Lymphocytes was 10. monocytes 17, and I will leave it at that for the first part of the labs.
Azim, do you mind just including the liver function tests
Sure.
and the renal function tests?
Her liver function exam. Okay, her AST was 70, her ALT was 80, alk phos was 217, calcium, albumin was 3.4, protein 6.1, bilirubin total 2.1, anion gap 8, and her creatinine was 0.62, BUN was 8.
And if I could just make one more request, Azim, do you have a chest X-ray or a CT scan, maybe just some preliminary imaging for us to review as well?
Pull it up. I believe, yes. So they went straight to a CTA for this patient because they were concerned about PE. And on the CTA, it didn't show any evidence of PE, but multifocal pneumonia was noted.
All right, thanks so much, Azim, for giving us that additional data.
And I guess I should just add one more since it's the last. The patient also had a troponin drawn, which was 0.21.
0.21, got it. Thanks so much. And Azim, just so I know, how many more aliquots do you think we have? No worries. I just want to make sure that you don't want to. 2 more. Got it. Okay. All right. So we got quite a bit of data here. Maybe I'll just take a quick stab, and then Robbie, I'd love your input as well. And we can go in order here. Actually, let's go in the order of relevance. And really, we were concerned about hypoxemia. You see here, the tachycardia and the hypertension is likely reflective of a sympathetic response to the patient's hypoxemia. And of course, you know, we'll probably get a lactate level 2 in the next aliquot of information. But here, when we did the arterial blood gas, this verifies that the patient has a low PaO2. And Azim did a terrific job. He told us that this was before the patient was put on any supplemental oxygen therapy. That's a very important maneuver before you get imaging to know if someone has a shunt or not, because those with shunts don't respond to supplemental oxygen. And as Robbie mentioned, those who are hypoxemic because of a decrease in respiratory drive or COPD or asthma will respond really well to the oxygen supplementation. So now when we couple this ABG with the patient's CT scan, and of course we have to ask the question, what's the severity of this multifocal opacification that's occurring in this patient's lung? But I assume that would explain the patient's hypoxemia. One thing to be cautious about, even if we had a chest X-ray in this patient that showed multifocal opacity, I think it would still be appropriate to get a CT with contrast, because just because you have one diagnosis in a patient who's immunocompromised with a background of cancer doesn't mean you don't have other diagnostic possibilities like a pulmonary embolism. But here we ruled out vessel pathology, so now we're straight in parenchymal pathology. And we also have to be cautious in interpreting this patient's inflammatory response, just given that she is on chemotherapy. So then we just dive into what causes opacifications. Robbie already shared that DDX in the physical exam when we auscultated crackles. And the radiologist will be able to use clues like air bronchograms, Hounsfield units, whether there's pleural involvement, to prioritize amongst the various causes that fill up the alveoli. So what are those various causes? White blood cells in the form of pus or inflammation that may occur in the setting of infection. And I think we have to consider a multifocal pneumonia here that is progressing to acute respiratory distress syndrome. Of course, you have to calculate the over FiO2 and rule out cardiac etiology to land on a diagnosis of acute respiratory distress syndrome. I think that would be prioritized for me. Other possibilities include fluid. We see that this patient has a little bit of a troponin elevation, and that's odd, right? That's odd. Go back to what Robbie said. How many young patients have coronary artery disease? So this prompts you to look at her past medical history. You see she does have findings suggestive of metabolic syndrome. So she may be at risk of premature atherosclerosis of her coronary artery disease. So yes, demand ischemia is a possibility here, but we're gonna need to see the troponin kinetics. Because if this troponin remains elevated, then I'm moving away from demand ischemia and I'm going into maybe myocardial inflammation as one example. Other causes of troponin elevation that stay persistent include infiltrative disorders, which cancer can infiltrate the myocardium. So right here, we just need to know the trends of that troponin, and we shouldn't dismiss it to just say this is demand ischemia, given the young age, despite knowing she probably does have some premature atherosclerosis with her past medical history. Since I've spoken for so long, I think the CBC is quite interesting, Robbie. I'm just going to hand the mic to you, my friend. Add whatever you want.
That was so brilliant. We all wish we could listen to you forever, though I appreciate you leaving me the juicy part of the CBC, which I love. And, you know, the CBC, if I had to first interpret it, we see anemia and thrombocytopenia. I'll tell you that anemia and thrombocytopenia is difficult because it represents a middle ground. A middle ground between what? If you have an isolated deficiency in one of the 3 cell lines, it's more likely that it's peripheral destruction. So you have isolated thrombocytopenia, isolated anemia, or isolated leukopenia are much more probable to be a destruction problem. The other end of the spectrum is pancytopenia, where all 3 cell lines are down, and that's where you are much more likely to have a bone marrow problem. And we are stuck in the middle when you have bicytopenias because it could be both a bone marrow problem or a peripheral destruction problem. So what clues can you use to help you prioritize one over the other, knowing that it could be either of them? And tempo. Acute diseases are much more likely to be peripheral destruction. And if we had baseline hemoglobin and platelets, we'd know that for sure. But there's another clue here, and that clue is the MCV. Now, the MCV can be elevated from primary bone marrow issues like myelodysplasia or the toxic effects of chemotherapy, or the absence of nutrients required to make red blood cells like B12. But acute microcytosis is almost always a reticulocytosis. So I will prioritize a destructive cause of anemia and thrombocytopenia primarily because the syndrome appears acute and the MCV is likely but not exclusively reticulocyte counts. So what can destroy platelets and hemoglobin at the same time? Well, that's, my friends, we have to go back to the river of blood and understand whether it's an environmental problem, a membrane problem like an antibody, or something inside the red blood cells and the platelets like an infection. And when I say infection, I immediately first think of Kushal, and then I think of Babesia, malaria, tick-borne diseases, et cetera, et cetera. What priority should be given in the absence of clarity? Environmental causes. Why? Lethal. And the truth is you'll make progress with a smear if you see schistocytes, spherocytes, or if Kushal can tell us if there's malaria inside patient's red blood cell. So here I'm already thinking, does this person have a microangiopathic hemolytic anemia because they have macrocytic anemia and thrombocytopenia? Microangiopathic hemolytic anemia is DIC until proven otherwise, but you can prove otherwise very quickly by looking at the coagulation parameters, which I don't see here, but I'll assume that they're not flagrantly normal because the esteemed Azim might have told us that. So MAHA in the absence of DIC is either TTP or HUS, but the presence of cancer alters the differential diagnosis. TTP is unlikely in cancer patients. HUS is unlikely in cancer patients, but what can cancer patients get? TTP. Malignancy-associated microangiopathic hemolytic anemia is described and is actually part of the spectrum of what Reza was talking about with tumor thrombotic microangiopathy. But more pertinently, when you apply cancer plus MAHA, you get cancer-causing MAHA directly. you get what's called Kasabach-Merritt syndrome, which is this fascinating diagnosis where you form abnormal blood vessels, usually from a hemangioma or an angiosarcoma, and the abnormal blood vessels break down cancer. It's really, really cool. But most important of all is to consider a drug-induced cause. A drug-induced cause of microangiopathic hemolytic anemia. Tacrolimus, cyclosporin are notorious, and guess what? So are the VEGF inhibitors. The VEGF inhibitors like bevacizumab. So for me, I'm starting to wonder, hey, what's the lay of the land here? Is this a microangiopathic hemolytic anemia, either augmented by the known hematological disorder of Fanconi's anemia or the drugs? Or are we dealing with a chronic bone marrow issue that is now just an innocent bystander to what Reza was studying, which is the cardiopulmonary complaints? What do we do next? You have to get a peripheral smear, and you have to make sure that this isn't something acute like a MAHA. And if it's not, then you probably go back and be like, well, can I understand Fanconi's a little bit better? And is it somehow related to what's going on now? All right, I'll pass the mic back to Azim.
So a coag panel was not ordered. I'm just now realizing that. Not at any point during this patient's stay, but I believe a blood smear was ordered. Trying to get it right now. It's slow. Okay, here we go. So for these categories of describes it as there were vacuolated neutrophils present, platelet sufficiency was decreased, large platelets were present, macrocytes were moderate, and there were moderate numbers of teardrop cells. I can't get access to the rest. And a lactate was ordered for Reza. It was a 2.2. That's it for that aliquot. Unless you want more.
Yeah, why don't you give us more to work with?
So the a cardiology consult was ordered for an urgent bedside echo, and an EF of 30 to 35% was calculated with moderate global hypokinesis. No valvular disease was present. The patient was started on empiric IV cefepime, and I'll leave it at that.
Maybe what I can do is I can kind of round out the discussion on the heme stuff, then pass the mic to Reza. And the heme stuff is complicated. I think vacuolated neutrophils are evocative of a chronic bone marrow disease, as are teardrop cells, which might go back to mapping onto the patient's Fanconi's anemia. I heard that the platelets were large. Is that correct, Azim? Or were they low?
The platelets were low.
Low. Okay, so we've confirmed thrombocytopenia, which is important because it's not uncommon to see a patient as pseudo thrombocytopenia, which is that the machine counts the which when as an artifact of collecting the platelets, they can clump, and the machine is misled into thinking they're low. So I'm reassured by the absence of schistocytes, by the absence of spherocytes, and the absence of inclusions inside the smear, which moves us away from an acute process more to a chronic bone marrow process, which would be compatible with the Fanconi's anemia, I assume.
Thank you, Robbie, and thank you, Azim. The case is getting interesting. You have me at the edge of my seat, my friend. I think this is interesting. We now have a pivot point in our approach. Remember when we applied the base rate disease in aliquot 1, Robbie said we gotta anchor ourselves in the cardiopulmonary world. And here, though we have multiple opacifications within the lung, the question becomes, what's filling up those alveoli? Is it infection? Is it edema? Those are the two most likely etiologies in this case. Now let's use the new heart failure with reduced ejection fraction as the center of gravity. But let's also be open to multiple diagnoses in this case. Let's not try to find one diagnosis to explain everything. I think as the patients are more advanced in age, or if they're immunocompromised, you got to be open to multiple diagnoses. So I think cefepime was the right approach here to just assume this is a pneumonia until proven otherwise. But now we have an echo result, and we have to ask the question, how is that going to change our approach? So HFrEF, we have a really good scheme on HFrEF, which is actually courtesy of the Cardio Nerds co-founder Amit Goyal. And basically, if you want to teach, like if you're in the hospital teaching and you have 1 minute to teach about HFrEF, you want to just discuss the most common causes of heart failure with reduced ejection fraction. The majority of HFrEF is due to coronary artery disease. This is 2/3 of heart failure with reduced ejection fraction. What else causes HFrEF? Valvular disease, which this patient doesn't have. Arrhythmias, whether it's atrial fibrillation, PVCs, if a patient has a pacemaker, for example. Toxins are a common cause. Hypertension is another common cause. And don't forget the idiopathic category. But in this patient, again, with this sort of global myocardial dysfunction, the troponin elevation, we have to be open to the less common causes of heart failure with reduced ejection fraction, meaning a non-ischemic cardiomyopathy. So I'm going to be very interested in that next troponin level. If that troponin level is staying elevated, not downtrending, not going up too much, now I'm at the peak of that troponin pyramid. So here I'm now overlapping schemas, HFrEF with troponin elevation. So I think we have to be open to the possibility of a myocarditis here. And if you ask the question, what results in myocardial inflammation? Toxins like cocaine, chemotherapy drugs. And I don't memorize every single chemotherapy drug. This is just an input into Google. There's no reason to waste space in that brain addict memorizing every side effect. It's just knowing that such side effects do exist. In a young patient, we need an HIV test. This prompts me to think of viral causes of myocarditis. There are other causes, which I'm actually not going to entertain yet. There's also stress-induced cardiomyopathy that generally has the apical sparing, Takasugos, because the octopus shaped apical sparing on the echocardiogram. So that's another possibility. Usually that troponin goes up and down. So what would I do next? I would get a repeat troponin. I would diurese this patient because maybe we are dealing with pulmonary edema. I would continue antibiotics. I would see what the pro-BNP is as well. Although, you know, it's not going to really change much in terms of my diagnostic analysis. If I'm concerned for myocarditis, I would get a cardiac MRI with gadolinium. And there I would expect sort of non-contiguous delayed gadolinium enhancement of the myocardium. If we confirm this diagnosis of myocarditis, then we have to start thinking about what the etiology is. And here, the meds are something to consider. Robbie, anything to add to that analysis, my friend?
Absolutely nothing. I'm right there with you. All right, Azim, give us more, please.
Okay, so several pulmonary and ID was consulted. And I think what I'll do is offer their, well, actually, so a repeat CTA was done. Let me first offer that interpretation. And it said findings can be seen with inflammatory and infectious etiology, such as atypical or atypical pneumonia, less likely edema, and trace bilateral pericardial effusion was noted. Cholelithiasis also was probable cholelithiasis. The pulmonary team believed that it was less likely edema causing the patient's presentation. And this was day 2 of the hospitalization, or day 1, sorry. And so they thought it was more of a pneumonia, less edema. When ID was consulted, they thought it was more edema, not as much as pneumonia. So the ID team recommended IV Resofin and PO doxycycline. And I forgot to mention that the cardiologist had started Lasix, like you said, Raza, and I'll leave it at that right now.
Azim, it's the old debate, the cardiologist versus the infectious disease doctor. We see this often. Thank you, my dear friend. And, you know, I feel like I spoke quite a bit the last aliquot. So Robbie, please analyze this data, please.
I think you summarized it so well. You know, we say that when we talk about infiltrates, we say, is it blood, pus, water, cells, etc. But the truth is, it's very hard to make progress. And we make progress by studying the extrapulmonary features. You see this liquid in there and you're like, well, is there evidence of heart failure with the elevated JVP and lower extremity edema? It must be water. If you see this fluid in the lungs and you see a Y count of 30 that's neutrophilic predominant in an immunocompromised patient, oh, it must be pus. You see this fluid and you're like, oh, the patient's anemic and they have glomerulonephritis, it must be blood. And so here, the lay of the land is hard because the patient has evidence of cardiac issues with the troponin and the echo, so that prioritizes fluid. But the patient is immunocompromised because of a chronic hematological condition, cancer, and chemotherapy. So I think the truth is, when we're in medicine, we're often in search for or. Is it A or B? And not uncommonly, it's A and B. It's pus and water. And I completely agree with the experts in this case and have nothing more to add. ID is probably right. There's reason to think about pus with what we just outlined. And cardiology is probably right because there's reason to have fluid. And there's no reason that you can't have both. So the ultimate factoid, I think, is pus is not allergic to water and water is not allergic to pus. They frequently mix together in the back of your lungs, which is a really sad reality, but one that's so Azim, please tell us more. What will shake out? Pus, water, blood, cells? By the way, I should say cells are important to think about in a patient with cancer. You can have lymphangenic carcinomatosis or infiltration of alveoli by cancer. So that's really something you can only diagnose by bronch and only something that you entertain if the infiltrate remains despite antibiotics, antifungals maybe, and diuresis.
So there were, to answer, Rosa asked for repeat troponin as well. And a repeat value was at 0.15. And then sometime after that, it was at 0.09. And the patient continued to do better, but the patient was improving. No shortness of breath or chest pain. The patient was continued on that antibiotic regimen, and she was responding well to the diuretics. A repeat, I think it was a chest X-ray was done, and the teams agreed that it likely was pulmonary edema, and that the repeat chest X-ray showed that the pulmonary edema was lessening. I will leave it at that, and I think then I'll reveal the diagnosis.
Thank you, Azim. Oh, sorry, Ravi. Do you mind if I go this time? Thanks. Yeah, of course you don't mind. You never mind. Azim, this is so important. Why? Response to a therapeutic intervention is critical in prioritizing the DDX. Let me say that again. Response to a therapeutic intervention is critical for prioritizing a DDX. For example, if I told you someone has polymyalgia rheumatica and you gave them steroids and they did not improve, they don't have polymyalgia rheumatica. In a patient with the multifocal pneumonia, you do not expect that chest X-ray to clear. There's no way. It takes 4 to 6 weeks for imaging findings to clear. I'm not saying that this rules out the possibility of a multifocal pneumonia, but it certainly supports the idea of water in that alveoli. In fact, here's a great mnemonic for all of you who are going to be starting your residency. If you see a patient in decompensated heart failure from flash pulmonary edema, think of the LMNOP mnemonic: Lasix, morphine, nitro, oxygen, positive pressure, and upright posture. LMNOP. Usually we do the Lasix we give oxygen therapy, we make them upright, and we give BiPAP. You'll see the lungs go from white to black. From white to black. And I got an epic text message from Robbie. He likes where I'm going with this. So I think, Robbie, where we are here, we have to ask the question, why is someone this young having decompensated heart failure with reduced ejection fraction? I think that ends up being the question. And the first branch point is there coronary ischemia? There is reason to believe premature atherosclerosis of the coronary vessels, but again, I don't think we can just settle there. This is someone I would want to do first an ischemic evaluation. And this could have been a coronary CTA, for example, or even a nuclear stress study. And then if that is not explaining this patient's newly decompensated heart failure, and I don't think it will, then I want to evaluate the myocardium. Here, I think a cardiac MRI with gadolinium is very helpful, though I believe you can do the SPEC study as well, and that could be quite informative. So what would I do next, Azim? I think she's feeling better. I think this is decompensated heart failure. The question becomes, why does she have HFrEF? I would do both an ischemic evaluation and I would evaluate the myocardium to see if we're dealing with myocardial inflammation. Robbie, anything to add?
I think that I'm right there with you. I think in many ways we can represent this problem as acute, unexpected heart failure and ischemia. Things that are easy to check off and improbable, but easy to test for or consider are thiamine deficiency, which occurs in 50% of patients with cancer. Hyperthyroidism, which is sometimes sneaks up on you as a complication of a drug. So maybe bevacizumab and thyroid. And then at the end of the day, could this be some sort of drug-induced myocarditis or malignant infiltration of the heart? Those are only ridiculously the rare considerations after you listen to what Reza said, ischemia. But I would say, remember that patients with cancer are higher risk of thiamine deficiency. So here I'd be getting a TSH. I'd be wondering, hey, should I give this patient thiamine or not for that possibility? But I think the name of the game is ischemic eval and cardiac MRI.
So the patient was improving clinically and was ultimately discharged after a 2-day stay. I think the more obvious diagnosis that the patient ended up having, it was multiple. She came in with acute hypoxic respiratory failure, the atypical pneumonia, transaminitis, and then the last one was non-ischemic cardiomyopathy, acute decompensated heart failure secondary to non-ischemic cardiomyopathy. I saw the patient yesterday with my preceptor, who's a hemonc doctor, and he arrived at the conclusion that this patient likely had a very rare side effect to the bevacizumab of ventricular dysfunction, and it's only reported in like 2 to 4% of all patients who are on this medication. I saw some comments about hypertension as being a side effect, and that's a much more common one. But this entire time, she had started the second cycle of that chemotherapeutic, and as I said, it started. Her symptoms started about 7 days after the end of that cycle. That's the current case resolution. She's pending an evaluation by a cardiologist, I think, for an angiograph. But right now she's sort of in no man's land because her cervical cancer won't be treated because they're not going to restart the chemotherapy. So right now it's sort of a wait and see of how really what the cardiologist says, and I think also really what the hemonc doctor says.
Azim, thank you so much, my dear friend. And I will say this, that if you're worried about a drug-induced myocarditis, this is a medical emergency. It's almost like acute coronary syndrome, where you're going to be giving these patients high immunosuppressive therapy as you're waiting for the workup and confirmation. Maybe here that wasn't the case, just given how great she looked and that her EF wasn't less than 10%. But really, myocarditis is not a benign condition, especially when it's related to drugs or really drug-related myocarditis. So for example, I had a patient who presented with HFrEF, extremely volume overloaded, was on a checkpoint inhibitor. We were most suspicious for checkpoint inhibitor-induced myocarditis. And before we even obtained a cardiac MRI with gadolinium, we started high-dose immunosuppression, just given the morbidity of a delay in treatment. I imagine here, Robbie, we went back and forth with you. Maybe it's just the severity of this patient's presentation. Said, okay, we have time. She looked great. She wasn't worsening. She didn't get any immunosuppressive therapy. And they're like, we can follow this up because every disease, even TTP, has a mild form. But in my experience, if you do have like HFrEF, volume overload, drug-induced myocarditis, it's really a medical emergency, like mononeuritis multiplex, which recently I'm framing as the acute coronary syndrome of the peripheral nerves, or the strokes of the peripheral nerves.
Incredible, absolutely incredible. I completely agree with that. It's humbling to learn about the depths of how many things, like Reza said, you can't learn the side effects of chemotherapy, but you should definitely look them up. And I think looking up bevacizumab and learning, as Azim just taught us, that there are case reports of it being associated with heart failure is amazing and very educational. Thank you as always for joining us on VMR, Azim. You've discussed so many, and it's your first presentation. Clearly, like, you look at the chat and how educational it was and how much people enjoyed it. Thank you. Last but not least, take us home, Rafa, please.
Okay, so first, thank you, Azim. Very, very interesting case. It's just brilliant and very hard to keep up. It's actually very hard to keep up with Rabi and Reza, and with this case, it was even harder. So apologies for any mistakes that I could make. So we had a young woman with worsening shortness of breath, and we started with the dyspnea pyramid, which the most common cause of worsening dyspnea is related to cardiopulmonary disorders, but also in a young patient we thought about pulmonary embolism, pulmonary hypertension, vasculitis, and obesity, but there are many etiologies as well, like anemia, metabolic acidosis, neuromuscular weakness, anxiety, hyperthyroidism. And then we talked a little bit about cancer and non-cancer dyspnea. The chemotherapy side effects could be a problem, leading to dilated cardiomyopathy, lung injury, or actual lesions like metastasis with damage to the parenchyma and the vessels, or a hypercoagulable disorder leading to pulmonary embolism. And then we talked a little bit about hypoxemia. The pulse oximeter is not perfect. There are many inaccuracies, including racial bias, so not so accurate in Black patients, and also not so accurate in hypoperfusion and methaglobinemia that could be seen with cancer due to the treatment. And then we saw that if the patient responds to oxygen, it's a clue to true hypoxemia. And it could be a alveolar problem or a vessel problem. Alveolar problem, Rabi used to say like the alveolar is singing, so you could hear in the stethoscope. And they're usually filled with blood, like GAH, but also with water that could be due to a cardiogenic or non-cardiogenic pulmonary edema or pus. And then could be also be a disorder with atelectasis, a collapsing alveolar. And a vessel problem could be shunting or microthrombi. And when it comes to anemia thrombocytopenia, Rabi reminded us to think that isolated anemia could be a destruction problem in the periphery. And when it comes to pancytopenia, it's more of a bone marrow disorder. And then when we combine anemia and thrombocytopenia, we have to think about MAHA, and we have two urologic emergencies like HUS, TTP, GIC. GIC has increased PT and PTT, and we see schistocytes on the blood smear. And then Reza reminded to think about heart failure, reduced ejection fraction, the main cause including CAD and hypertension, but also valvular disorders, arrhythmia, dilated cardiomyopathy, and also idiopathic causes. And then finally, I really loved this mnemonic, LMNOP. It's when it comes to ischemic chest pain management, it stands for Lasix, morphine, nitroglycerin, oxygen, positive pressure, and upright posture. So thank you, everyone. I hope everyone had a good time. I did. And I hope everyone have a good, I don't know, holiday. Some places have holiday today. So take time, enjoy your day.
Cool. Thank you, Rafa.